Okay, I think we're going to go ahead and get started. So I'm calling to order the third meeting for the task force. We've been moving right along, and hopefully we'll be able to get some things down as recommendations for our task force to study the methods to address the shortage of radiologic technologists, nuclear medicine technologists, and respiratory care practitioners in the state, and to develop a plan to address the shortage. My name is Bernadette Mealy. I am co-chair along with Matthew Green. So we will be we've been leading the charge along with our constituents and all of our members for this committee. So the first thing, I'm going to stop sharing here, but this is the agenda. You all you've all received this. Just talking about a few things before we go ahead and move right into things. I'm going to go ahead and share my presentation. This is always a struggle, isn't it? Let's go. No, that's not what I want to share. Center. Okay, you all see the slideshow? Yes, perfect. All right, so we are, today's meeting is part of Public Act 2397, Section 44. We've been tasked with looking at the different areas of the profession that are slated to be in this shortage. So our discussion today is going to be centered around status of the task force, challenges, rationale for addressing the shortage, looking at the vacancy rate. So hopefully we are in a good place with that information. I think that we've received some information, so I'm looking forward to hearing that data. We're also going to be talking about and having recommendations and discussion associated with that. Bear with me. I don't know what happened to my slide here. So just talking about the impact to the state. We have 2 more meetings that have, hopefully I'm going to be able to, we'll be able to get this done. So you should have received a link already about the 2 meetings sent for November and December. Want to be able to refine and define the recommendations for all of our areas. We've talked about grassroots advocacy and how the importance of advocating for legislation is going to be an important part for all of our areas. So the radiologic technology field, our nuclear medicine technology field, as well as our respiratory care practitioners. And so letting the lawmakers know what how the public is going to be impacted or how you feel about issues and that there's a collective voice that will make a much greater impact than just our own task force here. So the shortage itself is not new. It's not specific to Connecticut. So I'm going to speak specifically about my area just because that's what I'm familiar with is radiologic technology. So our profession itself, we've experienced the same shortage back in 2003. So we had these similar areas of shortages that attributed to the increase in the demand in services. And at the height of the imbalance, there was a height of imbalance between how many techs there were and how many procedures were being ordered. In 2000, that rate was at 18%. It was reported by the American Hospital Association. So that meant that at that time, we had 1 out of 6 jobs that were unfulfilled. So then they looked at different areas. So they looked at the reason why we were in this deficit, and it was because of the increase in patients. We looked at the number of imaging procedures that had soared. And then the number of people that were entering the field at that time had plummeted. And then a lot of people had left due to retirement or just overall dissatisfaction with the profession itself. So there were some short-term strategies that were used for addressing the shortage at that time, awareness campaigns and scholarship programs that tend to be short-lived. And then there was long-term stability that was discussed that talked about regulation and career ladders, and we will get to those areas as we continue to go through today's meeting. So I'm going to stop sharing there. And we'll go ahead and lead into the next area of the agenda. And so I am going to hand the floor over to our group. So Dr. K and Mr. Kidwell and Ms. Hall.
Thank you. I don't know, Dr. K, would you like us to go first or do you want to go?
Sure. Yeah. Go ahead, please.
Okay. So thanks, everybody. Paul Kidwell at the Connecticut Hospital Association. And last time we met, we discussed trying to get some more granular information related to sort of the subject areas. So we polled our members and just for a reminder, it's primarily the 27 acute care hospitals in the state, and asked and actually took the disciplines from the last agenda and pulled those to get some additional vacancy rate information. My colleague Kat Hall led that work, and she has a couple of slides to share and can give a little bit of background information related to how we surveyed, what we found, and some of the response rates. Kat.
Thank you, Paul. Okay, I'm gonna share my screen here. Hopefully it gives me no trouble. Okay, presentation mode. How do you like that? Can everyone see? Can't see you.
That works. That's
Okay.
great.
Okay, so our survey results, like Paul said, we asked about vacancy rates in these areas. We asked members just to report on what they had to date. We also just asked a question about budgeted FTEs to see if we could put that into like the context of vacancy rates for some of these areas. Not everyone commented on every single section, but I imagine that those who commented on those who provided information relative to what is relevant for the services they provide and stuff like that. So this is the average vacancy rates that we have based on the responses that we got. So respiratory care practitioners around 14%, nuclear medicine technologists were around 21%, the radiologic technologist 23%. Bone densitometry we didn't get that much data for that area. CT was pretty up there. IR, vascular and cardiac, not much data to be meaningful to report. For MRI and imaging, we had about 20%, mammography 16%, radiography about 49%, and then radiologic assistants, not that much to report from that aspect. But the survey highlights we did find was that the highest categories were radiography, CT, radiologic technologist, and then perhaps the interventional radiology, radiologic assistant, and bone densitometry weren't that, sorry, stop sharing, but that's, but those weren't as popular as categories to report on.
And we certainly can circulate this so everyone has it at hand and you have it. But in those categories, there were instances where we only received like 1 or 2 responses and didn't feel comfortable that it was that we could at least tell you all that it was a characteristic of all of the hospitals. And so we didn't even feel comfortable like making an assumption there. Karen?
So can you give us any clarification on who was polled specifically for respiratory? Who was polled and who responded?
Yeah, so the poll includes, our HR executives received the survey as the main request. And then we have varying affinity groups for each of those. So we have a respiratory therapy group that was included in the request. And it was a mixed bag whether the HR colleagues would respond on behalf of the hospital or system, or in some instances, we received direct responses from the specific disciplines. So it wasn't universal in that
And
regard.
did you get pretty good response rates? Do we know what kind of if you got them from larger hospital organizations? Because with respiratory, there's not that many big hospital organizations, and the data that we were getting was quite a bit higher as far as the vacancy rate, as well as one of the factors was the temporary the travel therapists and temporary physicians that aren't really addressing the permanent need.
Yeah, we did not ask about temporary workers, but I can say our experience just generally, and it's more in nursing than in respiratory therapy, is that our reliance generally on travel professionals in the state generally is higher than our colleagues in the Northeast and nationally. So that's a broadest generalization, but it has come down from sort of the height of the pandemic over the last year or so. But we're still ranked pretty high related to the how much we're relying on temporary personnel. Related to the percentages, I think we had a fairly good response rate, but as you note, what is happening in a community hospital, say at Middlesex Health, versus what's happening at Yale New Haven Health, that's a different experience related to vacancy. So I think our findings generally are we have pretty critically high vacancy rates in all of these disciplines.
Yeah.
And so I guess what our takeaway from the survey results was the work of the task force is important because we've identified these areas as of critical importance. And different than, say, in nursing, the pool of people to draw from is significantly smaller than in these disciplines. So even a modest vacancy rate in some of these disciplines indicates one need, but also it's harder to fill that position because there's a smaller pool of people. So I think those are our sort of broad takeaways from the numbers we saw.
Yeah, and I think, and that makes sense. When we polled rather the larger healthcare organizations, we were finding a 30 to 40% vacancy rate, and that didn't include travel therapists. So, but as long as we're identifying it as a major need, that's fine.
Yeah, we did not. I think our takeaway from this was there is a significant need in the state in these areas, and we should. And we're sort of, for us, it was an evidence of the reason why this task force exists and why we need to keep pursuing it.
Thank you.
Yes, thank you, Mr. Kidwell and Ms. Hall. I know it took a lot to be able to get that information, but we do appreciate the hard work that you put into that. Are there any additional questions?
I actually did before I go on the outpatient side. One of the slides, it had radiologic technologists and radiography as separate categories. Was radiologic technologist supposed to encompass all of it as a total, or was it clear on the survey what the difference between those? Because I'm not sure I'm clear what the difference is. A radiography generally means X-ray, but if anything, some of your lack of data for bone densitometry and frankly, and also the IR, there may be some overlap there with X-ray techs because they tend to be sometimes cross-covering, but and especially bone DEXA is an X-ray tech, so there's really not much difference, I would think. Was that delineated on the survey clearly, or?
Yeah, no, it wasn't delineated per se, but I do agree that there probably might have been some crossover there as well.
Yeah. I think, and the other comment was that I think regarding the question about temps, I know you were referring to temps in the respiratory sense, but that's also pretty prevalent in radiology as well. And my guess is that most whoever filled this out, most hospital administrators or managers probably, I know that at our place, it's not considered a full filled position.
That's
If
correct. Yeah, it's
I'm
not.
working it. It's still an open position that the hospital or the group is
Yeah.
actively trying to fill with a full-time position. And so my guess is that most people filling out the survey would not use a temp to sort of fill one of these. So they're really the openings, and that's important because temps are expensive and it's not a sustainable solution to this problem. And so you don't want to be including temps as sort of full-time workers here. You want to be attracting technologists and radiation therapists and all of these fields, people who want to work full time and not be a temp. It's
Yeah, and I'll stipulate that
enormous drain on the system. So
yeah, and when our hospitals calculate vacancy rates, they do not include
right.
temporary labor in that statistic. So they are looking for full-time or they're looking to fill the FTE
Yeah,
outside of the temporary labor.
sure.
And just for the record, when I was talking about temp, our general experiences with nursing, right? That's sort of where we have the most experience. But our what we hear from our members is that temporary labor usage is throughout the disciplines. We just have the most experience with nursing because it's the largest group of clinical employees.
Yeah.
Yeah.
Sense.
Go ahead, Karen.
Are travel therapist, respiratory therapists considered under temporary? Because I do wonder if that is calculated when we're looking at vacancies. I'm not sure that
Yeah,
whoever's
travelers.
filling this out would differentiate FTEs from travel respiratory
Yeah,
therapists.
our general experience is that they don't include travel. So travelers would be temp. I mean, I guess we should
Probably clarify that.
Yeah, our
for the
general
numbers.
experience is that when they're reporting vacancy rates, they are not including the travelers because that's temporary in their mind, temporary labor for a set defined period of time. But we can clarify
Yeah.
just to make sure we have information that we can bring back.
Okay, thank you.
Yeah.
Yeah. Okay, Dr. K.
Sure. So I'll share let me share. I don't have slides, but we drafted a little memo with the this is annoying.
Do you want me to share for you or you?
Do you have it? If so, hold on. It's saying allow Zoom to share. Yeah, if you have that memo, please just go ahead and share it. Sorry about that.
That's okay.
Yeah, so our survey, probably, as we've discussed here, there are less of us than there used to be, these, freestanding outpatient imaging centers. And so, the N here is 5. So I just preface that, you can take not necessarily with a grain of salt, but that, anyway, take it with a grain of salt. You can see numbers here. So for X-ray techs, shortage is about 12%, mammography 16 to 17%. Nuclear medicine, interestingly, on the outpatient side, there was not a shortage. At least the reported total, if you averaged over all the respondents, there were nothing. MRI 12 to 13%, CT a little less, actually, about 5%. Ultrasound 12%. So in total about 10-11% across all of these, and obviously some variation among these. The interesting thing is that at the end there was basically every practice said yes, they can use more technologists basically across the board, except, as I said, for nuclear medicine. But there was a question on does it delay patient care, and the answers actually ranged from one practice that said no significant delays to some that said it is a chronic and continuous issue. The reasons for that, I'm just kind of, I haven't talked with anybody who, out of respect for the people who knew that this would be an anonymous survey, haven't talked with them specifically about that answer. Some hypotheses about why that might be is that if you're reporting no significant delays, it might just mean that your volume is lower. And so perhaps that, you're caught up with your volume. You don't have a huge backlog of MRs or CTs or mammos to do, in which case, being short CT CT tech is just a matter of asking just a little bit more of your current techs in terms of shift work. Whereas I will tell you personally down where we are that, not having an MRI tech means closing a scanner, and closing a scanner means significant delay times. One scanner down, I'm kind of making this up, it might mean like a week extra delay in getting your scan. And there are places that sometimes we're reporting up to a month delayed of getting a scan. So, and that's measured in terms of, time from order to first available slot. So, there other possibilities. It could be just based on the location. Maybe some areas are feeling this a little bit in the state, feeling it a little bit more than others based on perhaps cost of living, in that area, based on other factors such as like competition in the area, how much competition there is for these techs in that area may be worse in some areas of the state than others. But I think in general, a 10 to 11% vacancy rate across the board is still a problem, and I think it's still something that needs a solution. Because even if a practice says that they are not per se, getting significant delays from this, when you still have a 10% vacancy rate, you're just one issue away, one FMLA request away, one unexpected illness away from all of a sudden being in a critical situation. And the idea is to get people into for their imaging as quickly as possible.
Thank you, Dr. K, for sharing that information. And I'm sure that we appreciate the individuals that also were able to participate in that poll. So thank you for gathering that information on the outpatient side. Are there any questions for Dr. K?
No, it's helpful to know about the delayed. We didn't ask about sort of delayed services, and that's an interesting, important question.
Well, we want to make sure we're solving a problem here. And
Yeah, exactly.
I think everybody here would probably agree that we are. It was a bit of a surprise that there was a practice that responded that way, to be honest with you. But I can't reach out to them individually because first of all, I don't know who it is. And second of all, it would betray their trust. So.
Correct. Any other comments regarding the vacancy rates? I think it speaks volumes already. So I think it tells the story a little bit about why we're here today. So we're going to start to discuss about what our recommendations are. So as we sit here, that's what our job is, right? Come up and develop a plan to address the shortages. I have some background information that I can share later, but I'm going to go ahead and I'll open it up to our representative for the nuclear medicine technologists. So Mr. Green, please.
Yeah, so speaking, the nuclear medicine programs and departments are pretty small. A lot of that stuff has gone to the cardiologist's office as well for the cardiac stress portion. That's big. And seeing that I never got response from the one program in Connecticut, I was kind of going off of, the documents that we just got, that the outpatient facilities don't seem to be lacking in nuclear medicine technologists. In the inpatient world, a little bit more, but it doesn't seem that the nuclear medicine technologists are the big numbers that we're missing. Speaking to my nuclear medicine technologists, their concern and the recommendation from our end, we're going to follow suit with y'all, but the recommendation on our end is to make sure that we keep that program open. A lot of them went to school in Springfield. There was a program that subsequently closed. The program at Gateway has closed before and has recently reopened. So they may not have as big a, vacancy rates now, but projecting in the future, if we don't keep that up and running and support from the state, funding, marketing and whatnot, that they can see that we might be in the same boat as the RTs and some of the other modalities that have higher vacancy rates. So that's kind of what I have.
Thank you, Mr. Green. Are there any questions? Okay. Ms. Griffiths, I'm going to hand it over to you because I can go ahead and roll into mine after that.
my screen? Can you see my screen?
Yes.
Yes.
So the recommendations from the respiratory, and I worked with Sajad and we worked with leaders in the respiratory profession in Connecticut. We kind of kept it short and sweet. So we recognize there are some recommendations that we would like that might not be legislative. So really separating it out and saying what is legislative recommendations that we think is going to help the workforce shortage for respiratory. We kind of broke it down to just a couple very, very small ones. And again, we know that respiratory, one of the problems is that we don't have enough awareness. So we do have to continually work on trying to increase awareness of the profession. It is a small profession. And actually, before I talk about this, one other comment with the shortages and the numbers that we talked about, we have to also keep in mind the growth of each of these professions. And I know respiratory is expected to grow rapidly in the upcoming years, and that's based on things like the aging population, but also increased technology. So all the things we've covered in previous task force meetings, we expect the shortage to increase, not to decrease. And one of the things we've talked about in earlier meetings too is the fact that we are not filling the seats of the current programs nationally and in Connecticut. So the recommendations that we have are for tuition assistance in the form of student loans, loan forgiveness, and that would be similar to what was happened this summer for nursing and some other professions. We'd like to be added to the loan forgiveness, and then grant funds. And the grant funds can go to things like equipment at schools or partnerships with hospitals, creating those clinical to better help with clinical rotations, but also to help raise awareness at the high school level with shadowing opportunities at hospitals, and also career fairs to help educate on the profession. So those are our recommendations. And these are the legislative recommendations that we have. Thank you.
All right. Thank you, Ms. Griffiths. Does anyone have any questions?
Sorry, I'm wondering on the loan forgiveness side, if I know the AHEC at UConn, they operate the loan forgiveness program for healthcare providers. And I'm wondering if they could provide us any information about whether the state currently has the authority just to add providers, or if we would sort of to the point around what's legislative, what's not, whether they have current flexibility under because I think it's a federally subsidized program. It's like the state and the fed. If they have any ability to make that change on their own, or if they do actually need the legislature to take action. I just don't know the answer to that. And
yeah, it's a really good point. I'm not sure if anyone here in this group knows the answer to that, or how we can find that out.
So I think the AHEC at UConn is operationalizing the state program, and so we could reach out to them and just ask for the requirements and what they have flex. I'm happy to do that if that's helpful. So
that'd be great. Thank you.
Okay.
Yes, please, Mr. Kidwell. Thank you. Any other questions for Ms. Griffiths? Okay, I think, she highlights some of the things that we've talked about, and I believe that she's right. I think it's for all of our professions, it would be beneficial to have these things as part of legislature. If you can please stop sharing.
I'm trying to, I'm sorry.
No, that's okay.
My screen on this got really small. Forgive me.
That's okay.
Let's see. Is it possible to do it on you? Am I still sharing?
You are still sharing.
Okay, I apologize. I'm not able to get back to that screen. Let's see, here we go. Are you able to do it on your end, or probably not?
I do not have access to do that.
Okay. I apologize.
It's okay.
I don't know why it's not giving me a stop sharing option.
Is anyone available to be able to have her stop sharing?
I'll tell you what, I will jump out and come back in because
Oh, there you go.
here, I think I figured it out.
All right, perfect.
Sorry about that, guys.
That's okay. That's all right. Okay, so I'm going to go ahead.
Just one other item, just on because Karen, you said it wasn't on the slide, but you said about just making sure that people are aware of the profession. I'm wondering if just like and there's a lot of discussion across the state around how do we get specifically high school students sort of aware of some of these professions. So maybe just in our list of things that we might want to recommend that I think that other groups are also recommending is how do we engage high school students in better understanding of healthcare careers generally and these careers specifically. And, you know, as an add-on to what some of the other groups in the state are contemplating.
And I do, you know, I've talked about in past meetings, partnering or having more connections with HOSA, which is, and I found out a lot more information. I did some digging into HOSA to see if that's something we could maybe ask for more state funds. Currently, HOSA is there's chapters, I believe there's 31 chapters in Connecticut that are students in high school that are interested in health fields. And these, they have 2 conferences a year, one in the fall, one in the spring. The spring one has competitions similarly to, so there's also other groups like this, like DECA, Future Farmers. There's actually, they're called CTSOs, and there's a number of them. They stand for Career Technical Student Organizations. And I actually talked to, it falls under the State Department of Education, and it's funded, what I found out was it's funded by the Perkins Federal Grant. One of the problems, some of these other CTSOs, similar to HOSA, have a lot more chapters and a lot more participation. And what I found out was that to have a chapter at a high school, you have to have an endorsement. So when teachers have to have an endorsement called 103, and it's a health science endorsement. And the problem is not a lot of people have that endorsement, and therefore I don't know what comes first. Not a lot of schools offer health science courses like they would offer STEM courses or business courses. So I think as a whole, for all health professions, we need to increase the amount of education in our high schools. And I think we need to have high schools offering these health science courses so that they can share all these professions and give students an opportunity to figure out what they might want to do. But it sounds like to get coverage under the Perkins grant, we need to have more people with this 103 endorsement. It's like a praxis exam. And then we need to have schools have positions where they have health science courses at their schools. So I didn't add it onto this because it's not necessarily something that we want to push for. I don't know that it's something we need to push for legislative changes to help these 3 professions, but it's something long-term that I believe will help with filling all the health science professions in Connecticut if we have more awareness at the high school level.
Thank you, Ms. Griffiths.
You're welcome.
All right, so I am going to just hop into RadTex and just talk a little bit about why we're talking about it. I know we've talked about it, we've discussed it, but really because of the unprecedented numbers of job openings that's affecting, so the impact of the shortage, workload increases. So we're talking about the factors that you're overburdening the remaining staff and potentially affecting the quality of patient care due to the potential delays in care and treatment from diagnosis to prognosis. So those are always the things that we want to think about, or I always want to think about when we discuss these things. So this is our organization, the ASRT, the American Society of Radiologic Technologists, hosted a consensus committee on the future of medical imaging and radiation therapy in February of this year. So it's all over the place. It's national. So I'm looking at national numbers when we think about this information that I'm going to share with you is from a white paper that they developed. And so their perspectives highlight the vacancy rates for all of imaging. So our story in Connecticut mimics what we see nationally. So you have vacancy rates here, and the estimated was an all-time high in 2023 of 18.1%. So we're pretty high. We're back to where we were back in 2003. And so these numbers are adding. And so when we look at this on a national level again, so this is just a survey from a national level, these are the vacancy rates that increased from these numbers are from 2021 to 2023. So these are the different disciplinaries, and this is encompassing radiologic technologists. So these are all of our areas. So not all of them, but the ones that have the most significant vacancy rate. So you can see your interventional cardiovascular went from 7.1 in 2021 to 18.6. CT is at 17.7. Sonography, 16.7. MRI is 16.2. Nuclear medicine, 14.5%. Mammography, 13.6. Bone densitometry, 6.9. So these numbers are national, and it'll tell the story at each individual state level. So when you look at that supply and demand, and this is just in radiography, that the number of individuals taking the exam itself for registration in radiography has declined. So in 2006, we had a peak of about 17,487 nationally taking that exam. In 2023, that number went down to 14,330. So it tells the story as to why we are where we are. Factors that play into this is that there were quite a number. So the survey was directed to medical imaging and radiation therapy professionals. So about 353 plus thousand invitations were sent out. Their yielding response rate was 2.5. So about just over 8,000 responded back. So it still had that confidence level. So most of the respondents, about 77.3% were employed full-time, 13.8% were employed part-time, remaining 9% were not currently working in the field. And those working were asked about their titles, et cetera, so forth. So what you see here is you see part-time employment was because those individuals were semi-retired. They didn't desire any type of full-time employment. They had family obligations. Turnover was based on not wanting to return to the imaging profession, working in another profession. And then others were reasons that they left the profession or left their most recent profession was based off of lateral moves, promotion, relocation, burnout, better pay, management conflict, and hours. So the task force looked at these areas of focus. And so they looked at things that we've already discussed, raising awareness, articulating career pathways, creating a pipeline. So these are things that we talked about, building a career ladder, expanding opportunities for education and training, and then sharing frameworks to be able to improve things such as workforce satisfaction, workplace satisfaction, employee engagement, and recognition. Key recommendations that the task force had, or that the white paper had indicated, we're building better career pathways. So I think it would be beneficial also, not only just for imaging, but this could be something that could be applied to our friends in respiratory care as well. So to draw more students into the profession and keep them on the job. So looking at ways that we can have state support in providing incentives to hospitals and other organizations to help to level up, to train internally. So I say level up probably because I couldn't think of the word that I was trying to say, but mostly about just taking the your entry level, your individuals who are working at a hospital, but not necessarily in a patient care role, and finding ways for them to become enter into the field through the field of either respiratory care, nuclear medicine, or radiologic technology. Incentives to hospitals and other organizations would help them to take on additional students, and it would help to also create career pathways to either management or educator. There's also things that we can ask for incentives to educational institutions to be able to create programs. And those programs that we're looking at is to allow for an imaging medical aid or a tech aid to be able to train, so develop a program that allows them to enter into the profession, but has them employed at a facility. So giving those in the form of those incentives, so just a scholarship way and a job as they go through a pathway into imaging. So those would be careers that would focus in on your patient care and communication, so transporters, any of your intake individuals, obtaining your PCAs, your patient care associates, anybody that could be like a phlebotomist. So those are things that you would look to be able to enter into this imaging, the medical imaging pathway. Another thing that has been discussed widely in our profession is achieving federal recognition. So currently, our profession is not the only individuals in the medical imaging and radiation therapy, their profession itself, that the U.S. Department of Labor and Statistics recognizes as professionals are not the technologists themselves. So the only ones that they think about are, so we look at a learned professional designation. And so if you have a learned professional designation as part of that Fair Labor Standards Act, we're pretty similar to nursing. We have the training, we have the education, we're compensated on a salary or a fee that's at a rate of not less than a certain amount per week. Our duty itself is in the performance of work requiring advanced knowledge that's intellectual in nature and character, and includes work requiring consistent exercise of discretion and judgment. I think that all the three professions themselves can say that this is what we do. And then we have advanced knowledge of learning, and we have to continue to be educated on ourselves. So with our professionalism, we would like to not be recognized as technicians or technical staff, that we would like to be able to achieve that federal recognition as professionals and have that same ability to be able to experience things such as recognition. Nursing has magnet programs, right? So they have those sorts of things. I think that will help to elevate our profession and to make us more, we are part of the team, but we're not recognized in that manner. Other things are recognition and reimbursement for radiologist assistants and other advanced practitioners. So the RA itself, as you all know, I'm a program director of the RA program here, so I will always advocate for them because they are the advanced level practitioner for our profession, that we need to have federal recognition and reimbursement for this profession that will help with not only the rad tech ladder and the elevation of profession, but it will also help with the shortage in the radiologist itself. So does anyone have any questions about? Go ahead.
So make sure I understand on the last bullet, is that notion is so that a professional could bill on their own rather than being part of the bundled payment that, say, the hospital or so more similar to a physician
Assistant. So not so much as not on their own. They would still work under the radiologist. We don't want to not work under the radiologist. That's not our value. But it would, I believe it would encourage more recognition for this profession as a complement to the field as opposed to a competition.
So billing sort of under supervision, but
Correct.
Separate billing for the service.
Correct. Yes.
And then, sorry, just so I also understand the learned professional designation, your thought there is it just brings additional prestige to the work. Okay.
Yeah, I think it is something that we've always talked about how our profession is not recognized that way. The only ones that are recognized in our field are radiation therapists and medical dosimetrists as professionals, and they're all part of our same field. So a radiologic technologist should also be designated in that same way.
Okay. Thanks. Sorry for the...
Sure, of course. Are there any questions for me about these proposed recommendations in addition to what Ms. Griffiths had added?
I would emphasize, when you're talking about outreach, you really have to emphasize that management piece, because I'll tell you, all of our all of our site managers are all former techs. That's, it's a well-established career path with a lot of, upward mobility. And I just think that maybe high school students don't know that, and that they think that they're going to get into this and be, like you said, with the prestige, just be kind of this, healthcare adjacent thing. But no, this is like an integral part of, healthcare that has a lot of growth potential to really make a career for yourself and grow into a leader and manager. So I like that part of it.
Thank you. I also had the educator path too, so that's always something.
Yeah, ditto. Yeah.
A lot of these, in all of our professions, it's not just an aging patient population that we have to be concerned about, it's the aging educators as well. So we're going to have to replace them with individuals who have been trained through the pathway or have elevated themselves through the profession. So providing these incentives would be helpful, and those incentives are the ones that Ms. Griffiths had indicated that would help us to be able to entice more into the field, entice more individuals into the field.
One of that struck me, and because we're thinking about it quite a bit in the hospital space, is the movement from, I would say, non-clinical to clinical, which I think is your level up to train, which is given we're competing with different employers in that non-clinical space, showing people the opportunity once you're just in the hospital for other growth is something that I know our hospitals are thinking quite a bit about as the ability to compete with sort of non-healthcare employers for talent.
And I think, to speak to that, Mr. Kidwell, a lot of people that I interact with in the hospital setting or in the outpatient setting have talked about that aid, right? So taking the pressure, we talked about burnout at our level of the technologists that are working to be able to perform all these exams. With a tech aid, you take some of that pressure off of them because they're doing that work that a tech aid can do, and let the technologist focus in on the exam itself. So using those individuals at that tech lead level to be able to level up or go from that non-clinical to clinical is something that they have all discussed, but there's no current mechanism. So that is one way that you can provide an incentive to an educational institution to be able to create these programs, to be able to see that and partner with hospitals or partner with organizations. Any other discussion regarding the recommendations that we have put forward so far, or any additions that you would like for us to, we don't want to add too many things. I think that we want to be able to be realistic with what we're asking for, but we want to make sure that what we're doing is feasible. So our next steps, I was given a template. So these are the things that we will be looking at for our report, which is due in January. So looking at, I'm going to be asking for help. So pulling things apart and seeing how we can write this. I've started putting things together. So executive summary, the introduction, the scope of the problem, guiding principles, where we are currently, so that these titles can change. These are just recommendations. And then what our recommendations are, and they can be in clusters. So it doesn't necessarily have to be just a simple, this is what we want, but we have to talk more about why. So going more into detail about each of the areas of focus, if that's how the direction that we would like to head into. Does anybody have any comments or questions?
I like this format. It's nice. I mean, I think it's very clear, and it sort of tells the story like down the line. So it makes the case. And so I think this format looks really good.
Thank you. It's the one the state gave me.
Yeah, they're very good at creating they have a lot of these task force. So
Yes.
Yeah, but I think it tells the story nicely.
Yeah. Yes. Go ahead, Ms. Griffiths. You are muted right now.
So with the recommendations, can we have some guidance as to, should it be specifically legislative recommendations or include everything? What is our goal for this next meeting as far as this kind of filling out this template?
So I am going to ask Representative McCarthy-Vahey if she has any insight as to how we should propose these recommendations.
Thank you. And forgive me, with just a few days left for the election, there's a lot of juggling right now between continuing the work and being a candidate. So can you just refine, I caught the tail end.
Sure, absolutely. So the question that was posed by Ms. Griffiths was, is there a format of how the recommendations should be presented in our report? Is there?
Gotcha. No, I think I took note of Mr. Kidwell's, agreeing that he thought it was a good format. And thank you to Beverly and Peter, Beverly especially, who's been doing this work for so many years and able to guide us. I don't think that there is necessarily a specific or recommended format. And also, by the way, forgive me for not being on camera. I think that when you think about the report, know your audience. So that would be myself and Senator Anwar and the other members of the Public Health Committee. And keeping in mind that we have multiple working groups, I have found that clear visual presentations that summarize things in an easily visually translatable way are very helpful. But I think you also have to weigh that with time on task for all of you who have very important jobs and work. So I don't think that there's anything specific that is required. I think it's how to best get the message across to the intended audience.
Right. I think, thank you very much. I think that obviously I've seen some reports, I've seen examples that they have provided, or an example that was provided to me that was pretty extensive. So I don't know if, 50 plus recommendations is something that we want to approach. I think that if we can hone it in a little bit, I think that would be best, because then we can discuss more about the rationale behind that particular cluster. What are your thoughts on that?
Thank you for giving me the opportunity to respond. I could not agree more. This is one of 5 or 6 other active working groups right now who we will be receiving recommendations from. If each of those groups gave us 50 recommendations, I can guarantee that we won't get anywhere near close. So one thing I will suggest, and I have often to other working groups, is to clearly prioritize. Because even if, for example, you give us 5 recommendations, it's possible that we would only be able to take up one of them. Mm-hmm. So just knowing, in terms of the process, for us as leaders, Senator Anwar and I have been, and Senator Summers and Rep. Caritas-Tetria, all of us have continued to have conversations and done the work throughout the year. Most of the ramping up for the legislative session will begin probably mid-December and the beginning of January, and all the different suggestions that are coming in from the working groups, as well as the fact that this is a year that legislators can propose any bill, whether it's budget oriented or not, means that there will be a lot of things in the mix.
Thank you very much for that insight. We appreciate it. I know that I'm not looking forward to writing a 100-page report. So we will try to not give 50 recommendations. So we will definitely come up with what we have and maybe refine it. So I will ask the committee further if there's any discussion about the things that we've discussed, and which of the areas do you feel as though we should add as recommendations? Go ahead, Ms. Griffiths.
So just on more clarification, I think we've talked about this before. I just want to make sure when we're doing this report, it should be on behalf of all three of the different professions in here. So if we're doing a recommendation, we may only want to do a couple recommendations, but it would hopefully positively impact the shortage of all three of these. Am I correct on that?
I think we can. Mr. Kidwell, did you have?
Well, I agree with that approach. Just given Representative McCarthy, he's good counsel to us. That to the extent we can identify priorities that are important to all three together, I think that's a really good strategy to getting something accomplished. Is my view.
Thank you. And then with all the other aspects of talking about the shortage, should we have a blurb for each, because there's three professions in this, should we set it up where we have something, we talk about each of the three things and then the recommendations will be all combined?
Yes.
And then lastly, is it possible to do like a sub-working group to prepare for the next meeting with the three people, with the people in the professions, so that we can come up with maybe one presentation that will address everything in here? Are we permitted to have a subgroup?
So I will ask, yes.
Yes, I think, may I, Madam Chair?
Yes, please.
Thank you. Yes, there certainly can be working meetings and working conversations in between to help get ready for that. And I do think, having, whether you call it a presentation or a, explanation, I think some of you may have heard me say this before. I often suggest thinking of us as legislators of receiving that information at the fourth grade level, not because my colleagues are not the most incredible, accomplished and intelligent people, but simply because of the volume of information that comes across our desk. And specifically, as I've been privileged to learn from all of you throughout this, there is a complexity here and there are differences. Even those of us on the Public Health Committee don't, necessarily fully understand the differences. We may all be beneficiaries of the services provided, but we may not realize the skill sets that we are benefiting from when we go to get a mammogram or an x-ray for a broken foot or any other such service.
Yes, thank you very much. I agree. So we can, the report, of course, will be comprehensive. It'll be a comprehensive report that will be sent. And then we can coordinate with Peter and Beverly how to do a sub-working group so that we can work on the report together, and then obviously have the input from then others within the committee.
Thank you.
Thank you.
I'll just as someone who's not in, I would support that, learning from the professionals to help lead us on the recommendations. So I support that notion.
Thank you very much. Any other questions or concerns? So you all should have received your links for our meeting in November and December. I was trying to be proactive, so hopefully we can get that on the books and to be able to finalize times. So we will, at the next meeting, I'll send an agenda out once we are able to get our working group together. I'll send materials through Peter and Beverly. If there's anything that you have, any questions, please send them forward through Peter and Beverly, and we can disseminate them or give them to the group at another time. Any questions? Any further discussion? Yes, Ms. Griffiths.
I think you said you're going to do this, but can you send the outline for what we need to complete to the group?
Yes, I'll send that through
Thank you.
Peter.
Thank you.
All right, thank you. All right, if there's no further questions or discussion, I'd like to adjourn. Do I have a call?
Motion.
Thank you. Second. All right, thank you all. We'll see you at the next meeting.
Thank you.
Thank you.
Thank you.
Thank you.